Hi everyone. Welcome to our first module on Introduction to Central Line Associated Bloodstream Infection, CLABSI. At the end of this module, you will be able to define the key terms and epidemiology of hospital-acquired infection and CLABSI in the intensive care unit, ICU, understand the sources of CLABSI, identify different types of central venous catheters, and determine the pathogenesis and risk factors. There are a series of questions after this module designed to stimulate your thoughts. Intensive care units, ICUs, account for less than 10% of total beds in most hospitals. ICUs have contributed greatly to the survival of patients with trauma, shock states, and other life-threatening conditions. ICU-acquired infections account for substantial morbidity, mortality, and expenses. Infection and sepsis are the leading causes of death in non-cardiac ICUs and account for 40% of all ICU expenditures. The incidence of hospital-acquired infections in high-income countries is between 3.5% and 12%, whereas it varies between 5.7% and 19.1% in middle and low-income countries. The frequency of overall hospital-acquired infections in low-income countries is 3 times higher than in high-income countries. More than 20% of nosocomial infections are acquired in the ICU. There is also an increased risk of resistant pathogens among patients in the ICU. The most common and clinically important infections acquired in the ICU are those associated with the supportive devices that patients in the ICU often require. For example, patients who are intubated get ventilator-associated pneumonia, catheter-associated urinary tract infection, UTI, in patients who were catheterized with a urinary bladder catheter, and catheter-related bloodstream infection with those with a central line, peripheral line, or even ART line, as well as surgical site infection. Familiarity with the common components of a CVC will help you understand and incorporate appropriate practices when handling these devices. First, the exit site is the place where the line penetrates the skin. Tunneled catheters may have a palpable tube going underneath the skin from the exit site. Second, the channels branching from the line are called lumens. CVCs can have a single lumen or multiple lumens. Third, each lumen will have a clamp or other sealing device to close the flow through the tubing. Fourth, the end of each lumen is referred to as a hub. Fifth, caps, ports, and needleless connectors can all attach to the end of the hub, ensuring that the line is not left open to the environment. The use of CVCs is associated with a risk of both infectious and non-infectious harms. Infectious harm due to pathogens entering the skin or bloodstream as a result of the device can be local or systemic. Local infections include infection at the CVC exit site or within the soft tissue along the path of the catheter, such as a tunnel infection or a pocket infection associated with an implanted port. Local infections may present with pain and redness of the skin at the exit site, along the path of the catheter, or over the site of the implanted port. Pus at the catheter exit site may also be present. Systemic infections include bloodstream infections or sepsis that occur in residents with central lines. Bloodstream infections may present with fever, a drop in blood pressure, also referred to as hypotension, or delirium. Central line-associated bloodstream infections, or CLABSIs, occur when pathogens enter the bloodstream while a CVC is in place. Non-infectious harms from CVCs include pain or discomfort at the catheter insertion site as well as challenges performing daily activities such as mobility, sleeping, and showering due to the device. A common and important non-infectious complication of CVCs is venous thrombosis, or a blood clot forming in the vein. Venous thrombosis can happen in either a superficial or deep vein and result in pain and swelling of the extremity. Deep vein thrombosis, or DVT, often requires anticoagulation, or taking in blood thinners, to prevent the clot from increasing in size and causing more serious harm. Now, let's go on to the central line-associated bloodstream infection. This is a primary bloodstream infection that develops in a patient with a central line in place within the 48-hour period before or on the onset day of the bloodstream infection that is not related to infection at another site. CLABSI is the third most common type of healthcare-associated infection, accounting for 24% of all hospital-acquired infections and being the most dangerous. It is also associated with increased length of stay, long-term disability, increased healthcare costs, and increased morbidity and mortality. However, most cases of CLABSIs are preventable with proper aseptic techniques, surveillance, and management strategies. A central venous catheter is a catheter that is often placed in a large vein in the neck, chest, or groin. It is a brilliant intervention used in the intensive care unit for monitoring hemodynamic parameters and intravenous therapy, for example, giving medication or fluid infusions and withdrawing blood for medical tests. These are the types of central venous catheter that are referred to by their function, type, and placement location, like peripherally inserted central line, non-tunneled, short-term CVC. Example: triple lumen or temporary hemodialysis catheter, tunneled catheters, and implanted catheters, chemoport. Non-tunneled CVCs are large-bore catheters inserted into the subclavian, internal jugular, or, rarely, the femoral vein. Placement of CVCs in the femoral vein should be avoided. To minimize the risk of infection, the subclavian site is preferred compared to the femoral sites. In patients with chronic kidney disease, the subclavian site is not recommended to preserve the vein. Non-tunneled lines are held in place by stitches or a sutureless securement device and can be at higher risk for dislodgement. Non-tunneled CVCs are intended for short-term use, often in the intensive care setting, for the delivery of medications that are unsafe to infuse into peripheral veins. They are not designed for prolonged placement or use outside of an acute care hospital. Peripherally inserted central catheters, or PICCs, are one of the most common types of CVC used in patients requiring prolonged IV therapy and are likely to be used outside the ICU. They are usually inserted by radiologists or specially trained nurses. PICC can be left in place for weeks or months. They are inserted in a peripheral vein, usually in the upper arm, and threaded into a central vein like the superior vena cava, as it is difficult to position in the central vein. PICC also has a high potential for occlusion. Tunneled catheters are designed for long-term use and can remain in place for months or years. They are inserted by surgeons or radiologists in the neck, groin, or chest. An incision is made in the skin, and the catheter travels under the skin before it enters a vein. This is referred to as being tunneled. It contains a cuff that anchors the line in place and acts as a barrier to the entry of skin microorganisms. They can be used to administer a variety of medications and also for specialized procedures such as hemodialysis. Implanted ports are surgically placed CVCs designed for long-term use, months to years. They are completely under the skin, meaning there are no external parts visible. A special needle, such as a Huber needle, is used to access the port. When the port is not being used, no device can be seen. You might only see or feel a small, raised area under the skin. In order to prevent central line infection, we need to decide which infection control measure we need to apply to prevent CLABSI. We must first understand how bacteria gain access to the central line. There are 4 common sources of bacterial contamination of the central line, which are skin organisms, followed by contaminated needleless access devices, hematogenous colonization, and contaminated infusate. The first common source is skin organisms, which are either endogenously from the skin flora of the patient or extrinsically from the hands of healthcare workers or contaminated disinfectants, which account for about 60% of all cases. As shown in the video, the organisms present on patient skin and healthcare worker hands travel outside of the lumen of the catheter and adhere to a fibrin sheath, where they multiply. This is the most common source of catheter colonization when catheters are in place for less than 10 days and occurs during insertion or shortly after. The next one is the contaminated catheter hub. This too can be caused endogenously from the skin flora of the patient or extrinsically from a healthcare worker's hand. This video shows how bacteria present on the surface of the catheter's needleless access device are transferred by a healthcare worker's hands or introduced to the catheter when accessed. Organisms migrate along the inside lumen of the line and attach to the fibrin sheath. Contamination of the inside lumen of the catheter is more common with catheters in place for a longer period, such as a tunneled catheter. The other source of infection is contaminated infusate, which is commonly associated with outbreaks. This video shows how intravenous fluids are contaminated, either through in-house medication mixing or by the manufacturer. In addition, the organisms can also affect the catheter due to hematogenous spread from distant infection sites. For example, a patient could be having pneumonia. Then that infection spreads through the bloodstream to the catheter, and then it colonizes in the catheter, causing a secondary catheter-related bloodstream infection. This video shows how organisms travel through the bloodstream to get an infection from another part of the body and then colonize in the catheter. Congratulations! You have completed the first module. Please proceed to the next module. This module is copyrighted under University Malaya. All right reserved under Faculty of Medicine, University Malaya. No parts of this module may be reproduced, stored in a retrieval system, or transmitted, in any form or by any means, electronic, mechanical, photocopying, recording or otherwise, without the permission of publisher.